I'd like to thank the organizers for the ability to speak today. I'm going to be talking about HIV subepidemics in Quebec and the benefit of treatment as prevention in the uh, averting of new transmissions and changes in the HIV epidemic. And phylogenetics is vital. In 2002, when we initiated the genotyping program, it became clear to me that it's vital that we use drug-resistant testing programs not only to follow drug resistance, but also to follow the dynamics of HIV transmission. And we have 11,000 people who have been genotyped in the program. 8,000 have been new infections diagnosed between 2002 and 2019. And what we do is follow the epidemic in three distinct populations: men who have sex with men, the subtype B epidemic, which is driven by large clusters in which 70% of transmissions cluster and 50% of transmissions are in large clusters, averaging 20 to 150 individuals sharing the same virus. And if we need epidemic control, we need to avert these large clusters. Among people who injected drugs, there was an epidemic, but epidemic control has been reached by 2012. We still have a subtype B epidemic among patients, but it is not spreading with large levels of clustering. And we have the introduction of non-B subtype heterosexual epidemic coming from countries in Francophone countries in Central and West Africa, North Africa, and France, and largely due to civil war and through migration and globalization. So each epidemic has its own epidemic drivers, and phylogenetics become an essential way to follow the epidemics. If we look at the men having sex with men epidemic, we can see a dramatic decline in the epidemic over the last post-2008. This is due to advances in treatment and also treatment as prevention paradigms. In 2009, the reductions in community viral load with the introduction of single drug therapies with tenofovir, FTC, the introduction of integrase inhibitors, and pre-exposure prophylaxis had led to a steady decline in the number of new infections. Unfortunately, it has not led to a reduction in large cluster outbreaks. Heterosexual epidemics are coming into the province and are limited clustering and haven't crossed over very largely into the population. So we really need to focus on epidemic control of the men having sex with men epidemic. If you look at an HIV trace map of all infections between 2002 and 2016 in gray and in 2017 in red, we see that large cluster outbreaks are fueling HIV spread among men having sex with men. These clusters are huge. It is not simply that it is added over a narrow range. These clusters are persistent. On the blue cluster on the right shows a cluster that existed in Montreal. 44 people got infected and the epidemic came to an end. But it moved and shifted to Quebec City. And in 2017, this cluster added 11 new infections. So we have to use trace type of methodologies and all these phylogenetics to follow the growth trajectories and try to break these cycles of large cluster outbreaks. If we look at 49 large cluster outbreaks and we look at them as individual sub-epidemics, each line represents a different epidemic. Heat maps show that these large cluster outbreaks are emerging over time. And in the 2014 to 2019 epidemic, we're seeing a shift of several large cluster outbreaks, sustaining the HIV epidemic by growing in incredibly high numbers in individual years, with anywhere from 8 to 20 people added to any given to different clusters. So if we look at HIV trace and ask what is the fueling factor of these large clusters, what you can see is the age range and a mixing of younger individuals with older individuals, and you see that it's recent stage transmissions that are fueling the HIV epidemic. If you look at sequence-based assays for monitoring the recency of infection, we see that it's recent stage infections that are fueling onward spread of the HIV epidemic. If you look at viral diversity and using 0.44% as a marker of 6 months or less infection, we see that large cluster outbreaks are being fueled by early stage infections. And later stage small clusters and singleton transmissions with limited size, it's because there are fewer individuals who are early stage infection and late stage transmissions. If we look at the violin plot below, we can see that singleton transmissions, introduction of treatment, has averted new singleton transmissions, but large transmission cascades of onward transmission among newly infected individuals still continues and needs to be a focus of our treatment as prevention strategies. If we look at the age of individuals in large clusters, we see a dramatic shift towards younger populations, and clearly we need to focus our campaigns and our public health policies towards individuals who are younger than 30, who are not aware of the dangers of HIV, who have not accessed health care, and who are not being treated in early stage infection to avert transmission cascades. If we look at non-B subtypes, we see the slow introduction of non-B subtypes coming from North Africa and France. So we have to be able to target our interventions to make sure that we do not have the spread of new non-B subtypes into the province, and that we are able to control the epidemic. So we've made tremendous progress in 1990 with 86% of people aware of their status. But of these 86%, the phylogenetics show that half of individuals are late presenters, and we're not reaching early stage infections to avert early stage transmission cascades. And we need to tailor our intervention for new arrivals to the province, because we have concentrated men having sex with men, and these people are vulnerable to infection, and we also need to avert transmissions among younger individuals.